Hello, I'm Cindy Goodwin. I'm a professor in the Occupational Therapy program here at the University of Findlay, and currently I am chair of the Interprofessional Education Committee. So thank you for joining us with your peers are here, as you've seen around your table, from a number of health professions in this room. Interprofessional education occurs when two or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes. That definition comes from the World Health Organization. And the colleges of health profession and pharmacy have been collaborating over the last 4 years to bring events like this to our students to support the collaborative skills that you're going to need for your practice in the future, whatever discipline you're in. So today we have students from pharmacy, OT, AT, nursing, social work, and nutrition, dietetics from BGSU have joined us today too, to give you, again, that opportunity to learn about, from, and with each other. You're going to hear a presentation, and then there'll be some cases that you'll have a chance to weigh in on from your perspective, from your discipline. So we hope your experience and participation in all of the IPE events that we have throughout the curriculum will increase your ability to provide patient-centered, team-based care one day. So our primary speaker today is Dr. Matt Stolik. He's a professor of philosophy here at the university. He's in his 20th year. He graduated from the University of Texas, Knoxville with an MA and a PhD in philosophy. There he was trained to be an ethicist, as well as a philosophy professor. His specialization is healthcare ethics, and his dissertation was entitled Training Medical Students to Care Compassionately. He's been a member of the Blanchard Valley Regional Health Center Ethics Committee for approximately 15 years, and he's written the ethics perspective for many cases in the American Journal of Hospice and Palliative Medicine. And by the way, I just want to put in a little plug. We'll be having another IPE event at the end of March, and that one is on the topic of palliative care. Dr. Stolik regularly teaches sports ethics, environmental and animal ethics, ethics and technology, and healthcare ethics. He's also been the organizer of a highly successful statewide Ohio High School Ethics Bowl for the last 5 years. We also have with us Kimberly Thomas. Kim is legal counsel and corporate compliance officer of the Blanchard Valley Health System. She graduated from the Ohio State University, where she received her bachelor's degree in nursing. She then went on to get a law degree from Ohio Northern University, and upon graduation, she worked as an associate attorney at a regional law firm where she gained exposure to the defense of medical malpractice claims and general healthcare law before returning to the Blanchard Valley Health System in '06. Then in 2015, she must have been bored. She went back and got her master's in law, in health law from Loyola University in Chicago. So Kim is a member of the Blanchard Valley Health System Ethics Committee and provides legal and ethical consults to physicians for clinical situations. So our agenda, again, will be a presentation by our speakers, and then you were sent some cases, which I hope you had a chance to take a quick look at, and we're going to give you some specific directions about what to do with them at that point. But until then, if you would please make sure to silence your phones, and then give a warm welcome to our first presenter, Dr. Matt Stolik.
Thank you. Thanks. I first thank Interprofessional Education Program for giving me the opportunity and Kim the opportunity to present today. And so what I'm going to be presenting today is a framework for ethical decision making, and it's based upon this book, which I use for my healthcare ethics course, Philosophy 221, and it's called Principles of Biomedical Ethics. And it's now in its 8th edition, 2019. First edition was 1979. So it's a book that has endured, and it's a really reputable book in healthcare ethics. So let's start by just defining our basic terms here. Morality is the norms about right and wrong human conduct, those norms you all learn growing up from your parents and teachers, communities. And we expect you know the norms coming in to talk ethics. And ethics is the examination and understanding of those norms. So we sometimes talk about doing ethics, and when we're doing ethics, we're examining and understanding those norms, which norms apply in which cases, what happens when norms conflict. So we take those norms you bring with you, you've learned growing up, and think about those, try to understand those in concrete cases. So in healthcare ethics, we're doing ethics, or the examination and understanding of those norms in healthcare contexts. And it's really cool to have so many different specialties here, so we can get different looks at the same case, from nutrition to OT to social work, etc. So we're going to look at 4 principles. These are the 4 major principles of the book: respect for autonomy, non-maleficence, beneficence, and justice. These are sort of like 4 prongs on a fork, and you'll find that you can deal with cases using these 4. You can sort of fit them under one of these principles and figure out that the principle applies to the case and can help you resolve the case. But I want to talk about virtues. One of the major criticisms of the book was that it's all principles, or these norms or standards, and no virtues, and that's false. They have a whole chapter on moral virtues. And I think we need to just pause and remember how important virtues are in healthcare practice. And this is focusing more on how you do what you do, how you deliver healthcare, not what you're doing for patients. And so healthcare, you're in the healthcare field. Care is defined in the text as emotional commitment to and deep willingness to act on behalf of your patients. Your patients expect you care in this way. And there are 5 other virtues for healthcare workers that are really important. Compassion, being able to suffer with and suffer as your patient. Discernment, you have a vision. You can see what's going on in the situation and how you should respond. Trustworthiness, you can be counted on. Your patient will tell you the truth, be honest with you. Integrity, you do what you claim to do. You state your values, and then your actions match those values. Conscientiousness, you follow through, you recheck, you make sure. So these 5 virtues are really important for healthcare workers. This is what will be expected of the moral healthcare worker, to follow the principles, but also follow them in the right way. So if you follow the principles, but begrudgingly, and you really don't want to, patients can tell you're going through the motions. And so we want not only following the principles, but also having the right attitude following them. And also with the cases, the virtues, they help you understand the cases. So if you have discernment, you can see that nutrition has something to say about this case, or OT has something to tell us about this case. So you open yourself up to different ways of seeing and understanding cases. Today I'm going to, again, just present this basic framework. I'm not going to present everything in this book, but talk about each of these 4 prongs of the fork, or the 4 principles of the framework, and major concepts sort of related to each one. And the virtues help us, again, better understand and respond appropriately in clinical situations. So compassion will help you do your healthcare profession in a better way. Okay, so the framework. This is the key of the presentation. What is a framework? Practical, you can use it. And comprehensive, covers a lot of situations. Set of overarching points, the 4 principles of reference. And these are chosen for healthcare. If we were talking about auto mechanics, compassion may not be a major virtue. musicians, athletes, they have different principles in those sort of occupational worlds and value different sorts of traits. So these virtues that I just talked about are relative to healthcare workers, which you all are in your different specialties. And in healthcare, unlike maybe auto repair or welding, there are vulnerable patients. They aren't at their best. They're vulnerable. They're hurting. They want to get better. They have to share intimate details. One of the most intimate, revealing experiences in our lives is in the room of a hospital or a medical facility. We'll bear all, information-wise and physically. The implications of what you have to diagnose us with and the prognosis you give us, these are really important. You think of a cancer diagnosis and people saying they were never the same after that. Their new life started after that. So that really doesn't happen at the auto shop. And major harms and goods involved. I mean, life and death, morbidity, mortality, really important. So here are the 4 principles, the 4 prongs. Let me introduce our stars of the show. Respect for autonomy. Most basically, this is a norm respecting and supporting autonomous decisions. Our patients choosing for themselves. We want to respect their values and their goals. Second, non-maleficence. This is a norm of avoiding harm. Do no harm. Third, beneficence. Relieving, lessening, preventing harm and providing benefits, balancing benefits and risks against risks and costs. And finally, justice. A lot of what they do in the book is on distributive justice and talk about whether there should be a right to health care and theories for and against that. But think also of the laws that you have to follow in each of your professions as well. So using the framework, this is what you're going to do with the cases. And the basic idea is you reflect upon the controversial case and attempt to point out how one or more of these principles are relevant. And those principles and concepts under those principles will come out as you discuss what's going on in the case. And we weigh and balance these. So beneficence tells me to override this patient's decision because I want to do good for them. Respect for autonomy tells me I should follow that patient's decision even if it's going to hurt them. So what should I do? Let them do something that's going to hurt themselves, respect for autonomy, or override that decision and refuse to comply because it's going to hurt them, beneficence. So we weigh these and we try to resolve the case. Which one of these is heavier? We work for consensus, but we don't always get it. But that's not a bad thing. If we can't get consensus, that doesn't mean we shouldn't even have a discussion, because there are still better and worse answers. But there can be legitimate disagreement over because of facts. What does an abortion mean to you, for example? And that word is so loaded, and we're going to have division on just what people think that means. Maybe insufficient information or evidence about which norms are involved or applicable in the circumstances, or maybe you weigh respect for autonomy more than I do in the case. So we're weighing things differently. There may be a genuine moral dilemma. You can decide in one of 2 mutually exclusive ways. You can't do both in a situation. Our authors say, there are some people who say there are no genuine dilemmas in life. You can always come up with a right answer. But our authors, Beecham and Childress, say no, that's not true. Life is messy. There are genuine dilemmas, and I sort of agree with them. And there may be conceptual disagreements. That might go back to the abortion example. So recognizing legitimate diversity is vital. Diversity of opinion is not grounds for skepticism about morality. So you're not going to dump all the moral norms you've learned growing up, just say it's all relative. But it's a reason for taking morality seriously, working to establish the most justified actions and decisions we can. And I think in the ethics committee, that's kind of what we do. Blanchard Valley, we get all these disciplines talking to each other, and you get different comments from each one. And you start seeing a consensus maybe build. But you want to hear from the different disciplines, like you guys are going to hear from each other today. So again, this book is the most recent one, the 8th edition. I don't even have it up here. I couldn't find any image of the first edition. If anybody finds it, you could shoot it to me on an email. I'd love that. But I can find the rest of them in my images. And that third one was the one I started with, the green one. And I remember telling my teacher, I read Beauchamp's book last night, and she said, no, it's pronounced Beecham, not Beauchamp, as the first one. So as you learn, you got to embarrass yourself a little bit, and you got to really put yourself out there. And I was reading the stuff, but it took me a while. And in teaching healthcare ethics here, I've just come back to the book, and I'm converted, and I think this is the best healthcare ethics book. Here Beecham and Childress. And they came out in this past year with their last, probably aren't going to come up with another edition, they're getting old. And they didn't really do much between the 7th and 8th. They tweaked it a little bit, but the principles have been there. It's a really solid textbook. Okay, so let's look at our 4 prongs for today, our 4 principles. First principle we're going to just briefly examine is respect for autonomy. Again, this means allowing people to decide about and control their own lives. 3 parts to an autonomous action. So you will determine whether or not this person's acting autonomously. If they aren't, there's nothing for you to respect. You're not going to respect an incompetent patient. You're going to try to help decide for them. But so if they're autonomous, the thing that we need to respect, they have intentionality, they have understanding, and there aren't controlling influences. And so when we're on the ethics committee and we have controlling influences on somebody, and we're told initially this is what they're choosing, but then we hear about this family member who's pressuring them to make that, and they're doing it, but they don't want to do it. Now we're getting into the ethics, and we're saying, well, this really isn't autonomous. This person is controlling that person. And when I talk to this person alone, they say they don't want to do this, right? This comes out in our talks. We get down to what's really going on in the case. So about these 3 components of autonomy. Intentional, basically think of a plan. If a person has a plan, we're going to say it's intentional. This word plan is really standard in the literature, in philosophy on intentionality. Versus it's an accident. It just happens to them. Understand. So if I haven't even informed my patient and my patient's already making a decision, how can that be autonomous? I don't know if they have the relevant information yet. So they may jump to conclusions before I've informed them. It can't be autonomous, or it's questionably. I don't know if it's autonomous. So they have the information, relevant beliefs about the nature and consequences of their actions. This can be limited in many ways. Illness, irrationality, immaturity. I think immaturity is going to come in when you talk about the case, the second part today. Deficiencies in communication. And as far as controlling influences, there can be external sources, relatives, pressuring them to do certain things, or internal states, maybe a psychological disease, something that keeps them from thinking straight. Not all influences are controlling, so we may say, yeah, that relative is pressuring them, but they know what they're doing. This person knows what he or she is doing, and so there's an influence, but it's not controlling them. So intentionality is not a matter of degree. You either have a plan or you don't have a plan. But understanding and controlling influences are matters of degree. And so we're not going to say you understand everything to be autonomous, but you understand enough. You understand the major risks and benefits of the procedure before you maybe agree in informed consent to go along with the procedure. And understanding and controlling influence is a matter of degree. So I could be autonomous, but maybe not as autonomous as other people. So they know enough. We're gonna go with their decision and respect their autonomy, but maybe they don't know everything. So there are degrees of autonomy. But in the hospital, we have to decide whether or not to agree to abide by a patient's decision. Somebody has to say, yeah, they're autonomous. And once we do that, we can move on. Now respect for autonomy is something we need to pay attention to. If they aren't autonomous, respect for autonomy has become much weaker. If they're not autonomous, there's nothing to respect. So now we're going to be more parental to them. We're going to do what we think benefits them, maybe a reasonable person standard or a reasonable patient, something like that. So there has to be a practical line. We have to say, you understand enough, and there aren't enough controlling influences. You have an autonomous decision. And there are rules under principles. Rules are more specific than principles. Principles are broader and more general. And under each of these 4 principles or prongs, our authors give us rules. So why do you tell the truth? Because you respect autonomy of other people. Privacy goes under autonomy. In other words, that's a reason why I respect privacy, because I respect people's autonomy, their right to decide for themselves. Protect confidential information, obtain consent with patients, and when asked, help others make important decisions. Also under respect for autonomy is the concept of competence. Most generally, it's ability to perform a task. So when you hear somebody deciding about whether somebody's competent, you want to ask competent to do what? It's decision specific. To sign a living will, to choose what flavor ice cream to eat in the morning. These are all different. And so you could be competent to do some things, but not other things. And if you're working with older people, you want to keep them as in control of their lives as possible. So you don't want to say you're just not competent in general and we can't work with you. That's really disrespectful. You want to say, well, you can still do so-and-so and such, and you're still competent to decide about certain activities and how your room's set up or what you eat, and that empowers them to let them decide about their own lives. Informed consent. You guys are all going to deal with informed consent. There are 2 types, basically, just signing the form and not knowing what the heck you signed. That's the usual, and not a legitimate informed consent, but it practically happens a lot, right? And the other kind is you actually have read, you understand what's involved, and you're agreeing to the procedure. So 5 elements, briefly, and we could talk a lot about these. Competence, again, closely associated with autonomy. Disclosure, understanding, voluntariness, consent. And so about voluntariness, if you will the action without being under the control of another person, and we've already talked about this, right? Influencing and controlling are different. And types of influence, you can influence a patient in many ways. Coercion, probably not the most used type of influence you'll use with your patients. Manipulation, I think you will manipulate your patients for their own good. Persuasion, also talk about framing risks and benefits. So how do you present risks and benefits? The way you do that can influence how often they will consent to procedures. Okay, our second principle, non-maleficence. Do no harm. And this one is, it's better to do nothing for a patient than to do something and make them worse. Don't make them worse than what they started with. So you're better off sometimes not doing anything. So they want an antibiotic and it's useless. Why would you give that? Don't give that to them. It's doing nothing. Do no harm. It can do harm, but it's not going to do them any good for what they have. This principle, do no harm, only requires refraining from actions that cause harm, and the rules are in the form of do not do X. So it's non-maleficence, do no harm, intentionally refraining from doing things that are going to harm your patient. Harm is really broad. Thwarting, defeating, or setting back some party's interests. Really broad. Thwarting, defeating, or setting back someone's interests. I could waste their time on a useless treatment or something like that, and they're paying for these treatments that you're giving them that aren't doing anything for them, and they're losing opportunities. If I would have taken that other treatment in the first place, I'd be better off right now. But I went through this sort of useless one, and so you've harmed them. You've wasted their time, you've wasted their money. They could have used other treatments or done other things if they wouldn't have gone through that. And harmful action's not always wrong or unjustified. So I may thwart or set back your interests, but I didn't mean to do so. I just ran into you accidentally. I've harmed you, but I didn't act wrongly. It was an accident. So wronging someone, our authors say, is different from harming. Harming is broader. And the rules: do not do X. That's the form for non-maleficence. Do not kill. Do not cause pain or suffering. Do not incapacitate. Do not cause offense. Don't deprive others of the goods of life. And I may cause pain or suffering at times, but if I do, I have to outweigh that with beneficence, with something that's good that they're going to get that outweighs that suffering they're going to go through. Negligence, and our lawyer here could talk for hours about negligence. And this is huge. Each one of you in your own specialty has a standard of due care. If you're a social worker, I have certain expectations of you, given your role, responsibilities. And so there are some actions any social worker is going to take and any social worker is not going to take. And so if you don't follow those basic rules, you're going to be negligent. And there are 4 basic elements of negligence. Again, any profession is going to have these. You have a duty to the affected party. Whether you're an athletic trainer, occupational therapist, pharmacist, you have a duty under that title or role. And you breach the duty. So you don't do what you should have done given your professional position. And then the party's harmed as a result. So I, as a pharmacist, I know that you're taking 2 counterindicated medications and that it's likely you're going to have seizures if you take these at the same time. But I fill them anyway, and I let you go out the door with those 2 medications. And you have a seizure and are in an automobile accident. You had a duty to that party to not let them have both those prescriptions. You should at least have pointed that out. If not, just not allowed that to happen. You breached it. You let them take both medications, knowing seizures could result. They get in a car accident, the harm. And they're going to argue with legal counsel that harm happened, and I think if they had those seizures, I would trace those seizures back to those 2 medications they took. I'm going to say that harm was caused by your breaching your duty. So you're going to owe them lots as a result of your negligence. The other side of this is if you follow your standard due care as a professional, you're really protected. And so if there are harms but you did your duty, you're in good shape. This is not doing your duty, and there's going to be a result paying for that. So by entering into all your healthcare professions, you accept a responsibility to observe the standards specific to your profession. And if your conduct falls below those standards, you're acting negligently. And so practicing due care is central to non-maleficence. A lot of non-maleficence cases under that one prong of the 4 are negligence cases. I sort of just go right to do no harm and negligence when I'm thinking of somebody who didn't do what they should have done as a professional. Think of the opioid crisis too, you pharmacy majors especially. Reflecting on due care of pharmacists. We're at least trying to find those ones that were being really negligent in how many opioids and different medications they were pumping out into the communities, and saying you had to have known, what you were doing, and this wasn't for a legitimate reason. Under non-maleficence, this comes up in ethics committee, withholding versus withdrawing treatments. So some people say, I don't want to start a treatment because if I start it, then I can't stop it. That's not true. That's dangerous to think. Sometimes you have to start a treatment to see whether it's going to work or not for any particular patient. But if you say, I can't do that because I can't stop it once I started it, you're not giving your patients even a chance to try things that may help them. So withdrawing versus withholding, don't use that distinction. Ordinary versus extraordinary. This is sort of older. I don't hear that too much, but It's vague, misleading. Just because something's extraordinary doesn't mean that we shouldn't use it. Principal treatment, and they say this over and over in this book, the principal consideration for treating or not treating is, do the benefits outweigh the risks? Benefits should always outweigh the risks for any particular patient, for that to be legitimate. And there's this rule or doctrine of double effect. I'm giving you all this morphine, and I know that you'll die as a result of all this morphine, but I tell you my intent is to relieve your pain and suffering. And I call the priest or the pastor before I start the morphine. That's how sure I am you're going to die. This happens a lot. Terminal sedation or palliative sedation it's called. And the justification for this practice is that, well, I can foresee you're going to die, but I don't intend your death. Right? So we can bear merely foreseen. They're against this, using this rule or doctrine of double effect, because merely foreseen effects versus intended effects, it's really hard to draw that line. Again, they say do a risk-benefit analysis. Don't go through this double effect. So I'm willing to give you this much morphine to kill your pain. I know you may die as a result, but otherwise you're in excruciating pain. So given your situation, it's better to give you this, and you may die as a result, but in your situation, the benefits of the morphine outweigh the risks. Food and water are medical technologies. Some people come into my course and say you have to always give patients food and water. It's inhumane to not do so. That's false. You'll learn more about that with your palliative care talk in a few months here. Sometimes patients in the dying process, they can't digest food and water. It hurts them. So you would be hurting them by forcing nutrition and hydration upon them. And so I should use a risk-benefit analysis for food and water like I do other medical technologies. Is the risk-benefit analysis such that I should provide them food and water? So no reason to think medical nutrition and hydration is always essential, a part of palliative care, or it necessarily constitutes a benefit. Not to every patient. You don't always have to treat your patients. There are two types of situations where you have no obligation to treat. Number one is when the treatment's futile. It's not going to work. You don't have to give your patients things that don't work or are going to hurt them. And hopefully as a professional, you're not going to do that because of what you've learned, and so you can protect your patient. Or the burdens or the costs outweigh the benefits. It's only going to make the matters worse. Better to do nothing, right? Do no harm. Life-sustaining medical treatments are not obligatory if the burdens outweigh the benefits to the patient. And it's impossible to determine what will benefit a patient without some kind of quality of life standard. So people say we have to keep quality of life judgments out of medicine. We can't. I have to know what quality of life this person has had, what they want to have. They can die in an ICU, they can die at home, they can die in a residential hospice. I mean, there are options, but for different people, different options are more or less attractive. Killing, letting die, they say don't use that distinction. And letting die is acceptable if medical technology is useless, futile, or the patient has validly refused medical technology. Advanced directives, two types: living wills, durable power of attorney for healthcare. Durable, meaning they continue to be in effect even when the signer becomes incompetent. And this is a gift you can give to your families. A lot of families do everything because they'd feel guilty if they didn't do everything in terminal situations. But when you have this form and you say, I don't want everything, that relieves them of the burden of making that decision for you. And they can feel much more confident not doing everything. And a lot of you would say, I don't want everything done if I'm in this kind of terminal situation. And yet you'll do it to your family members because you'd feel guilty not to do everything. So these give instructions in the event of your being incompetent, terminally ill. Surrogates, so surrogates make decisions for other people in the healthcare system, and sometimes we override the surrogates. We question surrogates. Again, ethics committee, this is important. And so I judge surrogates deciding for others. Are they able to make reasoned judgments? Are they just really emotional, sort of just freaking out? Do they have knowledge and information? This relative flies in from California and starts saying, I want this done, I want that off, I want this. Do they have information? If not, I'm not just going to do what they tell me to do, even if they're the legal surrogate. I have to know that they have the knowledge and information first. Emotional stability, similar to one, and commitment to the incompetent patient's interests, free of conflicts, controlling influences. So they have a case in this textbook where this guy has a heart attack and goes in the hospital, and a woman, his wife, immediately wants him, let's just take all medical treatment away from him and let him die. And he could easily be cured. And they found out she was cheating on him. And so she was trying to use the living will to have all medical treatment removed from him. If she wanted to remove all that treatment and there was a chance of curing him, I would question that decision on her part. I would say, do you understand? I could easily save him. So they overruled that decision rightly because she she didn't have a commitment to her husband. She had a commitment to her new boyfriend or whatever. And so when a surrogate is deciding, we should always think, is this in the best interest of the patient? The times we really challenge surrogates is when they're asking for something that's not going to help the patient or is futile. You want them to explain to you what is this going to accomplish for that patient. All right, third prong, almost there. Beneficence, do good. So positive, providing benefits and utility, larger types of medical decisions. Rules under this principle or prong, protect and defend rights of others. So I'm doing good. I'm not just avoiding non-maleficence, but I'm doing things. Did you know about this prescription plan we have? I noticed you're paying $150 for these meds, and you could get these for much cheaper. That would be a beneficent action on your part as a pharmacist. You're preventing harm from occurring to others. You see that somebody's at risk, and you're going to do something about it. Remove conditions that would cause harm to others. Help persons with disabilities. See, helping, I'm reaching out, I'm doing beneficence, not non-maleficence. Rescue persons in danger. And in this textbook, they argue we have a moral duty to rescue people in some situations, even people we don't know. So if you're walking past a drowning person and there's a life preserver there and all you need to do is just kick the life preserver into the water, you have a moral duty to do that. You'd be wrong to not do that. So some people say you have no duty to do good, to reach out. That's charity, that's extra. They say, no, there's a duty to rescue. There are some situations where you should help that person. Situations where it costs you nothing and it saves them everything. And expanded and continued access. We used to protect people. And then after the AIDS epidemic, things changed, and people wanted access to these drugs, even though they hadn't been proved effective. They had nothing else they could try. And so the philosophy used to be protect people. We'd rather protect them and prove things are safe before we give them a chance. Now we think some of these people should have a chance. And so we see a lot of expanded access, compassionate, expanded access, continued compassionate use programs. These things haven't been proven through FDA processes, but we're saying under beneficence, they ought to have this opportunity or chance. Under beneficence, a key concept is paternalism. You're acting like a parent of your patient. There are two parts to paternalism. I'm intentionally overriding my patient's decision, and I'm doing it for their benefit. And there are two types. If the person is not voluntarily making their choice, I'm thinking of somebody maybe severe Alzheimer's, dementia, and they're asking for something, but they don't know what they're asking for. It's not an informed decision on their part. I override their decision. That's soft because I'm not really overriding much of anything. I'm not even sure if they're autonomous or competent. Hard is the tough one to defend. That's when they are autonomous and I'm still going to override them. Boy, that might become relevant here in one of our cases pretty soon. Okay. I'm not going to give answers. Answers. Okay. Let's finally finish with justice. And justice, of course, has to do with laws that you must follow. But I always think law should follow ethics. There are wrong laws, and ethics changes bad laws and makes them better. I like to believe in that. Ethics and law. So, but there are different principles of justice. No one of these is the right one. That's why we have this huge debate in our society about health care coverage and right to health care. Some people think we should receive benefits equally. Others that it depends on the effort we've put forth or contribution. So we have a lot of occupation-based health care. And so if you work, you deserve health care. You've earned it. Merit, free market, if you can afford it, you should have it. Free market would be somebody really strongly opposed to a right to health care. One of the stronger opponents. And there are other principles we could use to determine how to distribute goods like health care. Properties we've used in the past have been IQ, race, gender. There's been horrible cases in medicine in the past of Tuskegee experiment, Willowbrook Psychiatric Hospital, people not being given what they should be given because of things like race, IQ, gender, race there twice, national origin, social status, ethnicity. These are irrelevant material principles and they're wrong to use. A big reason for this is these are things people don't choose about themselves. It's just how they're born, what characteristics they're born with. How can you punish them for those sorts of things when they have no control over them? Okay, here. Okay, here we go. I'm going to go here. Two main arguments for the right to health care, really briefly. Number one, collective social protection. Health care, our society owes it to their citizens to provide health care, like they give police. I don't have to pay for that, or fire department, or efforts against pollution. And we've all paid in, we've given into society. And for all of you, you work with patients, even though you're not actually a social worker yet. You still get to see patients and get out in the field. And so those patients are helping you. They're giving you this access to themselves. And so they say in response, we ought to be provided basic health care. And fair opportunity. So I need health to have an opportunity in life. And so like education, if I don't have that, I have very little opportunity in life. It's analogous to health care. And I think we're getting to a consensus in society, and certainly in the ethics world, that the best system is going to be one that guarantees a decent minimum or a first tier of coverage for everybody. And then if you can afford more, you get that second tier. But it's something you would have to get on your own. So society should at least provide basic health care. And the authors say it's like climactic in the chapter. All these different people are arguing with themselves in this justice discussion. And the decent minimum is something that they all seem to agree on. Libertarians, utilitarians, communitarians, egalitarians. But what is a decent minimum? What do we cut off at? Taking out wisdom teeth, taking an appendix out. Where do we draw the line and say we're not going to cover that? Wherever you draw the line, you're going to have arguments. The people below the line that aren't getting covered, they're going to argue. But once you have established this in your society, it's really beneficial, this decent minimum. And it's a legitimate way to select some procedures and cover those, exclude others. How about this? Can people forfeit their right to health care? They've freely chosen actions and they resulted in health problems, including like sexual promiscuity, smoking, alcoholism, sharing needles, and drug use. And so you end up with these major diseases. Should I pay for those? Isn't that your fault? And our authors are really reluctant to say, yeah, they forfeited their right. Our authors say you have to first show that lung cancer came from their smoking and not from environment or anything else. So you have to cause and effect relationship. Very hard to do. Second, they must have autonomously assumed those activities. So maybe they grew up and everybody smoked in their house. And so they started smoking at a young age. Well, I mean, they weren't autonomous to start. They were kids. Their parents turned a blind eye and let them go ahead and start to be smokers themselves. Not clear, and now they're hooked. And so is that their fault? Maybe not. No one theory will fully capture justice, but target goals for the big picture about the healthcare system, some form of universal insurance, I think at least the decent minimum. Acceptable incentives for physicians and patients to not play the system, make money for themselves. Fair rationing, not violating decent minimum, and put the system in pieces at a time. All right, we've arrived at the end here. This overall is just a very basic introduction. Again, I spent a whole course on 10 chapters of this textbook, and each of the principles has its own chapter, and they go in depth, but that doesn't mean you can't use this framework if you understand the basic 4 principles. And again, this framework makes sense of and helps you resolve ethical issues in healthcare. So you'll say, this is a respect for autonomy case, and we have to listen to this patient, or this is a justice case, and there's this law involved, and it takes precedence over everything else. Again, I want to emphasize how important virtues are, how you do what you do in healthcare. And I did my dissertation on compassion, and patients are so smart. They read you. They know whether you want a question from them or not, or whether you just want to get to your next patient and you really don't care. And if you don't believe me, think of yourself as a patient. And if you've been a patient, it's so valuable, the experience you have as a patient, to make you a better healthcare worker. Compassion. So if you've been a patient, you can relate to patients, and you suffer with and as they suffer. You discern, you see what's going on. You're reading your patients' nonverbals. You're reading them. You're listening to how they're saying what they're saying. You're discerning. And if things aren't adding up, it's gonna bother you. You're gonna work on it. Trustworthiness. You develop this open, honest relationship with your patients. And you could be counted on. You don't have ulterior motives for what you're doing. Integrity. You claim to stand for something, your code of ethics in your profession, social work. I'm a social worker, and so I do so-and-so. And then when the situation arises, you actually do that so-and-so. And conscientiousness, following through, completing your work, checking, making sure. Not just getting out of there as soon as you can. And so what we're going to do next are the cases, and these are 4 basic steps. It's not like you have to go through this in a rigorous way. But I say when you get these cases and you start discussing, in between here, my presentation and the cases, start discussing, attempt to identify the major issues. Well, this is problematic right here. This person's doing this. I think that's wrong. And your different disciplines will hopefully bring different points out. But we just want to start with a discussion. What's going on in this case? And then we're going to start narrowing down to something that's really definitive of the case. You want to narrow down. What's the major conflict? What kind of case is this? What is this? What's the decision we need to make here? What question do we need to answer? And then try to get a principle for and against on the question of what choice or decision is involved. Respect for autonomy, let's just do what this patient's asking us to do. Beneficence and paternalism, we need to override this patient. We can't let this patient make this decision. So I may get down to those two. And then you guys are going to weigh these. Well, I think we ought to let them do it. And in a lot of final exams and things, I'll have some on those kind of cases answer respect for autonomy, others beneficence. It's hard for me to say one's wrong, one's right. But I look for them to acknowledge the other side and then make their case for their principle. And that to me is good. They're doing it in a methodical and justified way. And so 4, we're going to resolve the case. We want to resolve the case. And in the hospital, in the real world, we got to make decisions. This patient's dying. You know, and this family member's on us, they want something done. And they're going to do this and this if we don't, right? And so we're going to make a recommendation. We've reflected about it, and we think this is the most justified thing to do. And after we've discussed it, I think a lot of the facts, information come out. We know much better what it is we're dealing with. So those first steps are really important. And then you would explain, respect for autonomy. We've informed this patient. They're autonomous. All 4 of those criteria of autonomy are met. We've gone over this with the patient again and again, and they keep telling us this is what they want. In the end, we have to respect autonomy over beneficence, maybe in some case. So should I fill a forged prescription? I'm going to start with a toughie for you pharmacy majors. It's written in crayon. I don't know. Forged prescription. So I've seen some examples of these. I was on a grand jury here, and we got some examples of these forged prescriptions. So in the first step, I would think you would say, talk about the role of the pharmacist and laws involved, expectations of your employer, if you feel that, other physicians, you know, who's the physician involved, if any. You're protecting your community, so that's important. And then maybe you get down and say, well, this is either I got to respect the autonomy of my patient and fill this prescription, or I need to step in and I need to not fill this prescription. And not filling it, I think non-maleficence do no harm. I would harm my patient, probably addicted or something. Also the community, these drugs are getting out there. And beneficence, I'm doing good for my patient. My patient may need an intervention here, bringing in they've gotten to the point where they're forging prescriptions. And so I get down to respect for autonomy. I just got to do what my patient says, crayon and all, or justice. I think justice would win this case, and I would say I don't fill the forged prescription, but I've used the process. And in the end, the laws that I know as a pharmacist, filling a forged prescription is illegal. And if I fill it, I'm being negligent, and I should be punished for it. So to practice applying this framework, we have facilitators, and I think Kim and I are the primary ones here. And we're going to join your discussions. It's not like we're giving you the right answers again. We just see you go through these 4 steps with each of these 2 cases. All right. Thank you very much for your attention.
Thank you.